Today, we're going to be continuing our series on navigating the One Big Beautiful Bill Act in the Rural Health Transformation Program series. The focus today is on how clinically integrated networks, or CINs, can help rural hospitals, health systems, and clinics navigate OBBBA changes now and ahead of the 2030 value-based care mandate. Today, we'll talk about what a CIN is and what it isn't, when it makes sense, and what it really takes to join or form one. You'll hear two complementary perspectives. We have Brittany from Cibolo, who will be maybe joining a little bit late, but hopefully she will be on. And then we also have Zach from Eastern Plains Health Consortium. And Zach is going to talk about standing up a CIN by 2026 across a group of critical access hospitals. So our goal is by the end, you'll have a clear view on the advantages of a CIN and what it can deliver, the challenges that it helps solve for value-based care, in the ways that you can get started. So my name is Jared Lisenby. I am the Chief Sales and Marketing Officer here at Azalea Health, and I'm going to be your moderator. In addition, I have Sean Frazier. Say hello, Sean, if you're out there. From Azalea.
Hey, Jared, thanks for letting me participate.
Yeah, hey, Sean, who works with hospitals in the Midwest, will add color. He's going to assist with some of the monitoring on the topics that as we discuss. Real quick, I've been asked to give some housekeeping notes before we jump in. So all attendees, thank you for being here. You're muted to minimize distractions. You can also submit questions anytime in the Q&A panel. You'll see that there. This is going to run around 45 to 50 minutes. We'll save time at the end for live Q&A. So anything that we don't reach, we'll definitely plan to follow up with after the session. The session is also being recorded, and we'll send you the link afterward. When you exit, there is a short survey. We love your feedback. It helps shape our future sessions. So we'll get started with a brief orientation from each, or from our panelists today. Zach, we'll start with you, Zach. Just a quick orientation on Eastern Plains, and talking about Eastern Plains in terms of CINs. Who's at the table today? Why CIN in 2026 is a strategic priority, where you see the gaps to solve, and so forth. Zach?
Yeah, happy to do it. Jared, thank you for having me. Sean, nice seeing you again. I am Zach D'Argon. Jared, good job not having to say that last name and letting me say it first. So I always appreciate that.
D'Argon, I got it.
That's right. I'm the president and the CEO of the Eastern Plains Healthcare Consortium. We are a rural health network of 15 independent critical access hospitals, a heavy majority of us in frontier counties. So, you know, we've been an entity for a little bit over 10 years at this point, all with the mission of being, how do we as a rural health network help our independent hospitals stay independent, stay fiscally solvent, and not just survive but thrive, and which is more important now than it's ever been, considering the landscape and the shift, you know, as it is in 2025 and heading into Q4 of 2027 with the Budget Reconciliation Act, or the OBBBA. Yep. Jared, you got through that OBBBA faster than I did, but I'm working on it.
It's OBBBA. I don't know.
Oh man.
OBBBA. There.
I won't touch that one.
Southeastern thing. I don't know.
Yeah, and you know, it's our role to try and align our 15 hospitals to create scale and to create a unified voice. So we do a lot of work in the policy and advocacy space to drive good rural healthcare policy and action, and mitigate poor healthcare policy. And we do that in an advocacy standpoint. We do a heavy amount of shared services as well, in education and development of our members. But really, you know, our focus as we head into 2026 and 2027 is really narrows things down to two strategic goals. Number one, what are we doing to grow our hospital volumes? And every county in our region, our population dynamics are decreasing, right? Over the next 5 years, none of our counties are predicted to see population growth. So for us, that means being more effective at retaining patients within the four walls of our hospital, right? Swing bed optimization, being more proactive with the patient panel, and improving our acutizations of what patients we can actually admit to our hospitals and challenging our clinicians to truly act at the top of their license. Strategic strategy number 2 is impacting the payer environment, and both public and private payer environment. Because in our setting, I'll get to it later, we're disadvantaged relative to the rest of the state. I know many of the listeners here feel equitably the same way. So really, when you boil down our strategy to those 2 things, clinically integrated network helps inform both of those strategies in a very significant way, from improving our quality and improving our data infrastructure, which will help us with retention dynamics, which will help us align our hospital outcomes, and longitudinally allow us to negotiate collectively with private payers and actually improve what our reimbursement rates can look like. So that's why, that's why I think I'm invited here today. We haven't been shy in that. A clinically integrated network is absolutely at the top of our list strategically heading into the next 2 years.
That's exactly why you were invited here today, to share that, your perspective of what's happening in the Eastern Plains. And then we also have Brittany. Brittany's on the call. Brittany from Cibolo. Good to see you. Thank you for being here. Could you give a 3 or 4 minute kind of just version of y'all's approach on high value networks and what that looks like in your world, and what are the big differences in your model, Brittany?
So I apologize, Jared, for the technical difficulties. I was sitting in the wrong room waiting to get in.
We are glad you're here. Thank you.
Yeah. Brittany Sachdeva, I am the Chief Operating Officer and co-founder of Cibolo Health. And I think that a lot of the philosophy, what I caught out of Zach's intro, is really similar. So what Cibolo does is we build clinically integrated networks, or high value networks, for rural independents across the country. They're state-based networks that we manage. So today we have 6 that are up and fully operational, several others that are in development. The concept of a CIN is not new, and we readily acknowledge that. CINs have been around for a really long time with sort of varied success, I would say. And so what we think from a Cibolo standpoint that makes our model different is that we do not own them in any way, shape, or form. So our networks are nonprofits, entities that are incorporated in their state of origin. They are member owned. And so if you look at our demographics, we have networks across the Midwest and in Ohio. They're all comprised of different size and type entities. They but all meet the definition of rural and independent. And so if you're a mid-sized PPS hospital, or you're an ultra small critical access hospital, it's one member, one vote. The CEOs of each of the member hospitals, they elect a board of governors. The board of governors then or directors manage that network and strategically make sure that we're moving in the right direction. So Cibolo comes and brings the administrative support, leadership muscle, and then technology and resources to support the care team.
Very good. So it's great context from both of you. So, when you think about today's reality and the pressure that rural healthcare leaders are facing, and where, CINs come in and help, Brittany, just a quick question, and this is around, why now, right? For rural leaders, OBBBA changes in the 2030 value-based care timeline. Where does a CIN relieve the pressure first? Is it financial? What are the measures, KPIs, staffing, payer conversations? What do y'all see? Cibolo.
Yes, I think it's all of the above, Jared. Each network has different priorities coming out of the gate. So there's really kind of 2 arms to our model. We have the clinically integrated network, or the high value network, and that's really where we're working towards entry and accelerating the value-based care journey for these facilities. The second is shared services, and that could be anything from we have our own staffing entity that's exclusively for our members, and guarantee best in industry pricing to get some of those contingent workers. We also have centralized care coordination infrastructure.
Right.
So each facility that comprise the membership, they come at this a little bit differently. Some just right away they want to get their money back in shared savings, and so that is a route and probably the quickest and easiest path. And then the ultimate goal long term is that we're getting into shared contracting and doing some of that more advanced work around meaningful value-based care for rural facilities and joint contracting, which, in our journey over the last several years really has come to be a significant benefit to the payers as well. You're working with one entity for 25 or 30 different facilities, and there's tons of economies of scale in that and efficiencies.
Yeah, totally makes sense. A lot of shared resources, shared efficiencies. Zach, I'll ask you just from your vantage point, what 2 or 3 of the top pressures that, making a CIN timely for just Eastern Plains, and what outcomes are you looking for?
Yeah, it's the 2 buckets. I'll kind of start high and dig a little bit deeper. The 2 buckets really are pressures that make this a top priority for us. Are number one, just the deterioration of our payer environment across Eastern and Southern Colorado, and number 2, the challenges that go along with it from workforce and our lack of aligned care coordination as it exists today, right? So when we think about the payer environment, I'm not listing anything anybody isn't acutely aware of, right? Or we're seeing radical increases in Medicare Advantage enrollment and Medicare Advantage denials, significant Medicaid re-enrollment issues, underpayments, Budget Reconciliation Act, and recently the state of Colorado had to make an $850 million budget cut heading into 2026, and to no one's surprise, Medicaid was a significant portion of that. So that the environment is kind of fallen apart around us, and we don't have a huge network of large hospitals to impact that. Where all of our hospitals from a payer environment are truly standing alone on an island. When we look at regionally, kind of our disadvantage when we look at Eastern and Southern Colorado, our private payer reimbursement relative to Medicare is 139% of Medicare. When you compare that with our counterparts on the Western slope, they're receiving 189% of Medicare reimbursements, and the hospitals in Denver are at 240% of Medicare reimbursement. So when we're over 100 percentage points lower than, for the same care, for the same quality, for the same procedure that a hospital in Denver is doing, it's really challenging for us to hit a margin and to maintain our sustainability. The One Big Beautiful Bill Act has the state of Colorado's application has focused on, and from direction from DC, and the federal delegation has focused on the need for expansion of a statewide clinically integrated network. So really, all of those environments have pushed us to raise our hand and say, if we don't hop on the train now, the train's leaving the station. And clinically integrated network is absolutely where healthcare is going. Brittany, to your point, it's where healthcare is for so many of us, and really where it should be. So we need to get to the point where we're leaving that station. The train is leaving the station. We need to be on board and aligned with the federal expectation as well as the state of Colorado expectation. If you want to be competitive and you want to be eligible for rural transformation funding or USDA funding in the future, we expect our networks are going to have to be tied to some sort of population health reimbursement model, and to us that means a clinically integrated network. The other pressure that we continue to feel is, as I mentioned, the workforce. We have extremely small teams, clinical leadership departments and quality departments of one person, and really having these small teams trying to manage some of those high acuity transitions with not a ton of centralized support from our network as it exists today. We really feel like if we can expand this clinically integrated network with our partners on the western slope of Colorado to create a statewide CIN, it'll help bridge that gap from that 139% we're being reimbursed to the 189% they're reimbursed, but also get us all aligned on our same quality measures and our performance measures as well. So, you know, I think those are the two pressures as to the why, and the why now urgently, because the payer environment is only going to get worse. We don't expect it to get better, so we need to become proactive, not reactive to that environment.
It's very interesting, and you said where it should be and where it's going, and you know, for other states that are on the call listening to this, I mean, it's just, you know, coming together, or you know, using shared resources and so forth just totally makes sense. I would ask to both of you, just as a follow-up, you know, what are some of the bigger misconceptions if someone's on this webinar and they're like, well, that just works in Colorado, or that just works in other places? What are some of the bigger misconceptions you hear about CINs in the rural market, and what's the reality of, you know, are they really misconceptions, or are there places that maybe they should ask questions around?
So
go ahead, Brittany.
go ahead. No, you please. I'll follow
Okay.
you up.
The two that pop into my mind, and I realize I'm a panelist, but I'm not a CIN expert, but I've learned a whole heck of a lot about them over the last year. The two misconceptions I kind of came to the table with when we first started going down this path is number one, a clinically integrated network is too risky because, Zach, a CIN means you have to take on risk financially if you underperform. I've come to find that that's not necessarily the case. There are clinically integrated network solutions where you can you can start simple with care coordination and quality alignment and sharing your data, and downside risk does not have to be the starting point, but a downside upside risk model is something to work toward. I think that was a misconception of mine, and that's the model we'll be pursuing out of the gate with our partners with Western Healthcare Alliance. Misconception number two is this is going to overwhelm our clinicians and our providers, and they are going to hate this, and they're not going to believe in it, and they don't want to adopt change. There's of course always providers in any network where you're going to have some less traction or more friction than others, but you know what we're really starting to articulate with our providers, especially in a model where we don't have to take on significant risk right out of the gate, is speed to launch to us is becoming really important for all of the things we've been talking about for the first 20 minutes of the phone call, where as uncomfortable as it may be, we're trying to kind of put the plane together a little bit on the runway as it's taking off, and asking our clinicians to lean into that and understand we don't have to execute perfectly straight out of the gate. We can improve. So, you know, our message is when a clinically integrated network is done right and structured correctly, this should be removing some work from the frontline teams by centralizing our data, by centralizing care transitions, payer paperwork, so on and so forth. So, you know, at any point we're communicating closely with our clinicians and creating communication platforms so that if anything isn't passing their sniff test, or if something is making their life harder and not easier, that's a red flag to us as the co-leadership team, as to maybe we're doing something wrong. So those are the two misconceptions that I brought to the table.
Thanks for sharing. Brittany, what do you think?
Yeah, I think those are really good insights from Zach's perspective. I would say, from my viewpoints, two of the most common misperceptions are, number one, that CINs are ineffective. And then number two, that this is kind of the march to acquisition from a large system. So one is that they're ineffective. Again, these things are not new, and I think there's been varied success, and lots of people have tried them lots of different ways. And so we are now, 3-4 years into getting really meaningful outcomes. And what we've realized is that the CINs work if you have engaged CEOs and leadership that want it to work, and you're coming into it with some shared goals and shared strategy. So I think that a lot of times I'll get from leaders or CEOs or providers, well, the FTC guidance for CINs was retired because they're irrelevant. That back in 1996, in the Federal Register, it says you got to share risk, you gotta, you have to pool resources, et cetera. And that's since been retired. This tenets still stand. But I think that looking at the way that CINs are administered differently has proven that there is a path. And to Zach's point, I mean, it was in the notice of funding, the NOFO for this $50 billion, they were specifically referenced as a strategy to be successful and get traction. Number two, that this is the path to acquisition. So I know there's been a lot of care collaboratives and a lot of kind of community connect, if you will, type strategies of large systems. This is not a path towards, at least in our model, this is not a path towards an acquisition or trying to reinforce the hub and spoke model. It's really trying to do the inverse of that. And that's why our model is this member owned, one member, one vote strategy. So if you come to the table and you have $1.5 billion in net patient revenue a year and you're a rural independent, you meet that definition, or you're a critical access hospital that has a net operating volume of 100 million, you get the same vote and the same say.
Right. Very true. Powerful insights. And thank you both for sharing that. So just for the individuals attending, we've talked about why now. We've talked about some of the challenges. I want to turn it now to joining versus forming. And so with that context on the table, let's compare the two paths, joining versus forming one. Zach, you've considered building versus partnering, to my understanding. What criteria mattered most? Is it, governance, cost, speed, independence?
Yeah, we've looked at every possible pathway we were aware of, right? And it's as I kind of mentioned our area, what I guess I should explain the structure that we are moving forward with in 2026, because I'm not sure if I've articulated that yet. As I mentioned, we have a rural health network on the western half of our state, which obviously is very different population dynamics, very different payer mix than the rural frontier, old, poor, sick folks on the Eastern Plains in Southern Colorado. That organization that we're going to be partnering with come January has had an ACO entity established for north of 10 years at this point, and they're in year one of their clinically integrated network. So we are, for lack of a better phrase, going to be kind of bolting on to their infrastructure that they have. And a big part of that as to why is scale felt very important to us. Improving our population and payer dynamics was very important to us. I've mentioned that currently the goal at the end of the rainbow for my hospitals is how do we get to the point, as Brittany alluded, kind of those more sophisticated conversations of actually engaging with payers. If we can go from a 10 hospital network to a 20 or 30 hospital network by being statewide, we think we're going to be more effective in those types of discussions. So as we go down the Q1 of 2026, really what's important to us is governance, right? That's probably our top priority out of the gate. We need to make sure that, as Brittany alluded to, our members have equitable voting rights within this new organization. Does this mean a joint venture with the Western Healthcare Alliance entity? Because we want to ensure that our member hospitals' independence is protected. We also want to make sure that my health network's independence is protected, right? We want to make sure that we continue to maintain our identity for what's best for our hospitals on the Eastern Plains, as well as my counterpart will want to do so for the same as her hospitals on with the Western Healthcare Alliance. So, I think that good governance structure, establishing that trust and the communication, voting, decision-making rights, so on and so forth, is going to be extremely important to establishing good buy-in from our hospitals as we look to join up with this group. And I think I mentioned it ahead of time, speed. We really felt like, given the current environment and how far behind, my personal opinion, how far behind our region was, in which only one of our 15 hospitals is a part of a CIN and only 2 of our hospitals are a part of an ACO. I really felt like we needed a solution that really accelerated the launch of getting started. So building alone, while we saw a ton of benefits to it, of kind of creating something that's unique and tailored to us, we prioritize the speed and trying to figure out how to make it work with our partners on the western half of the slope. So I think we'll, relatively quickly, we'll build a much stronger scale and a more appealing income and payer environment moving forward.
That's great. Brittany, anything you want to add to that? If not, I do have a question for you.
Go ahead.
Okay, so if you're thinking about, from creating a consortium, a rural consortium, and you're evaluating your partners, give us 3 kind of green indicators, red indicators you'd watch for any kind of CIN arrangement. What are you looking for?
Well, I would say number one, and the only way that our particular model works is if this is a grassroots effort. So Cibolo, we don't go and market. We have no sales team. We're looking for organizations that are interested in building this and they have local leadership that are going to drive it forward. So what we're going to bring is the tech staff, the population health platform. We're going to bring national physician leadership in value-based care and population health. We're going to bring centralized care coordination in a manner that makes sense based on what your internal infrastructure is. However, to actually make these entities relevant, you need what Zach mentioned, which is scale. So you have to have enough scale to be relevant, and you have to have local leadership that really truly own this. Because a Cibolo or any other entity that isn't part of the matrix of that community that is pushing this work forward, it just doesn't work. And so to date, that's been a really successful strategy. I think also knowing that none of this happens overnight. So you can't even begin to consider talking about these payer negotiations until you can emphatically prove clinical integration. So you have to actually do the work. You have to be clinically integrated if you want to stay on the right sides of your local and federal government. And so that means you've got to invest and commit to having clinical resources dedicated to some of this work. You've got to be willing to lean into some value-based care arrangements that probably aren't going to be the best value-based care arrangements. You got to start someplace.
Right.
An evolution. So I think just knowing what you're getting into, making sure that you have leadership that really owns, believes, and trusts that this is the right strategy for their organization, for their state. And then a willingness to exercise some patience because it takes some time.
Right.
Hey, Jared, this is Sean.
Yes,
I've actually got a question for Brittany.
Sure.
So Brittany, I attended the Nebraska Rural Health Conference in June. And I think it was Tyler talked about the Nebraska High Value Network. It was an interview actually.
Yeah.
Were the green flags you talked about there what Nebraska experienced, or was there anything different there? Because I thought what they were doing was pretty exceptional.
Yeah. No, so Tyler, that you're referencing, is the board chair for the Nebraska High Value Network, and they just had, they have a rural med co-op, as you probably know, in the state. So there was already relationships built, which really helps because in some states we're getting CEOs together that are neighbors that have never met each other. So that's absolutely the case. And we don't move forward. We have several states that we're working with that we're saying, okay, you guys, we're ready to go when you're ready, but you need to get, 5 more CEOs on board, and really, because we want to make sure that these are successful. So once we reach the volume, the scale and relevance that we think makes a difference, then we build them. And since the Nebraska High Value Network started, I think we've added 3 additional members, and with more coming on board.
Thank you.
That answer your question, John?
Yeah, no, that was perfect. Thank you. Jared, you're on mute.
Thank you, Sean. They got me, but I'm back. A lot of decisions that go in, deciding whether you're joining or forming and so forth. However, let's just say you make that decision, then you have to operate it, right? So what does it actually do? If you were to look under the hood and kind of looking at that day-to-day operational, what does it take, right? So Brittany, can you kind of paint that for us? What are the measures of set, how you aggregate data, what's the source of truth, just all the different things that you have to do to create coordination and, that would complement your local teams.
Yeah. Our focus has really been on EMR and payer agnostic solutions. So that's the other thing. All of these facilities are coming with a different set of infrastructure. And so we have a population health platform. It's called Cibolo Connect, where regardless of your EMR, we're able to do bidirectional feeds with clinical data as well as with payer claims data. Right. So that is one of the only kind of must-dos, is that's our single source of truth. So all of our shared contracts that we have, we house our performance in there. That's where, if you're a CEO, you're going and looking at what's my estimated return on this contract based on my team's performance. If you're a clinician, it's directionally telling you, where you need to focus and where you need to work down to the individual patient level, so that there is support. To the team that honestly, for a couple of reasons, has never been there before. These types of solutions are extraordinarily expensive. So a single entity very few of them are going to be able to afford the price tag that goes along. Well, when we scale it, and now, every state that we add or every new network that we add, then that adjusts the price down for the others that are already on board. So utilizing that scale to make access to these types of solutions accessible. Then, so for our onboarding, we set that expectation, and then we spend, before we actually put in place our formal governance, we spent about 3 months just doing a review of kind of all the things that Zach's talking about. What's the payer landscape look like? What's your MA penetration? How many of you are participating in value-based care? And then from there, we say, okay, incrementally, what can we all agree on as the couple quality objectives that we want to work on? Because every contract, we have started in states where literally we were handed a value-based care contract that is made for quaternary systems, academic medical centers. We're trying to plug this into a rural health clinic in the middle of rural US. And we said, we can't work on 16. So what are the 2 or 3 that we're going to work on? We just doubled down and we proved that with our tech stack, with our centralized care coordination, that we can indeed make progress. And then the next contract negotiation cycle, that particular example where we had 16 metrics, we now have 5. We get incremental improvement recognition. So instead of just hitting a threshold and you get your a portion of your value-based care dollars, now if you're making improvements towards the threshold, you get some credit and money for that. So I think it's a phased-in approach. Number one thing is coming up with our quality metrics, our core payers that we want to start working with, and then getting that centralized sort of EMR or technology agnostic source of truth.
Yeah, very insightful. Again, Zach, what do you think? Just kind of follow up on Brittany's comments as far as where do you start operationally? A lot of different things to look at. What's your minimum kind of
Yeah,
Bible.
you saw me nodding along with everything Brittany was saying. So not to regurgitate too much, but for us, first and foremost, it's primary care and care coordination. There's so much opportunity that exists right now for our hospitals to more proactively engage our patient panels in our communities. Again, becoming more proactive as opposed to reactive with our patient panels, with our annual wellness checks, chronic disease management, so on and so forth. So really, the hyper focus in that first 6 months is going to be, we understand what benchmarking and what good looks like from a quality standpoint. Let's use these new resources with our new partner to really focus on those types of opportunities. Number two, I think it's encouraging our members to truly adopt a measurement culture in a meaningful way, right? We are going to be having much more access and insights to real-time data than we historically have. That data ain't going to do us any good if we're not engaging with it and actually kind of creating actionable change. So I think those are the two huge focuses for us in the first 6 months. We, as Brittany and I've alluded to, you don't want to go approach the payers too quickly. That's a recipe for disaster from a financial standpoint. But what we are doing to kind of dip our toe in the water, Colorado's what's called a certificate of public advantage state, which is a bill EPHC 3 years ago got passed, which allows our hospitals to, through an application submission to the state of Colorado, allows certain safe harbors for antitrust concerns. And one of the applications that we got approved is for our hospitals to collaboratively and collectively engage private payers outside of a CIN, but as a single entity to have more meaningful discussions and negotiations around things like more consistent denial management, more consistent prior authorization approvals. If you approve an inpatient stay, we need to make sure you're not going to renege on that payment. So I think what we're hoping that certificate of public advantage will allow us to do in the forefront of this clinically integrated network is to start having the infrastructure to start having meaningful conversations for the non-financial aspects of the private payer environment and how they engage with our critical access environment, all with the longitudinal hope of, once we have some of that infrastructure in place, perhaps we'll be more effective in the actual financial discussion.
Hey, Jared.
Yeah, Sean.
Next question for Zach. So Zach, this is maybe 100,000-foot question is related to you forming the CIN. There's a lot of topics that you have to align your leaders on, and I've met a few of your leaders and they're not shy and quiet. And so as you think about that, what are some of the strategies you're thinking about employing or have employed to align people on some of these topics, especially those leaders?
Education first and foremost, and building trust with the hospitals that are already in this existing CIN on the Western Slope. I don't think Colorado is unique in this, but our rural CEOs are extremely collaborative, and over time we've truly kind of grown into that interdependence mindset of we need each other to be independent, and we need to rely on each other to do that. So like you said, they're not shy. They're also not shy to reach out to their peers on the West and understand good, bad, and ugly what this clinically integrated network looks like and what the opportunities are. And with that really does breed trust across this network for the one member, one vote mentality. I think the luxury of the model that we are pursuing, Sean and Brittany, to your point, it's a reason why Cibolo wasn't exactly the right fit for us. Is we're not going to have 10 hospitals in 2026 join this thing. It's pretty typical for our group to have the early adopters and innovators. I'd be thrilled if we had 3 or 4 hospitals dive into this thing in 2026, and as we prove and communicate and report out how it's going, maybe in 2027 we get 3 more, in 2028 we get 3 more. That's truly how I would anticipate that this will go, because some of our hospitals are opinionated, and we have some that believe in this model and want to jump in, and they want to be at the forefront of it, in the first class train car, so to speak. And we have some that, a couple of years from now are going to be chasing the caboose. But I think allowing some of their peers regionally to prove the concept and show the impact that it's had in engaging their community and improving the healthcare quality in their community is going to be what's helpful. So I think it's that's how we're approaching it. We don't expect our entire members to just join day one. It's going to be a little bit of an ongoing education process.
Thanks, Zach.
Yep.
Yeah, good question, Sean. And staying with some strategies, Brittany, on payer strategy. What are you thinking as far as, when does scale become enough? I think that's one of the questions we had asked. What does that look like?
So, and that is the philosophical question that I get asked it every single day. And the answer is a little ambiguous. So first, we have to look at each individual state. So we've got a network we're building right now that is going to probably start with 5-ish hospitals, but they're mid-size PPS independents, and they are very relevant and cover a lot of geography in a state. And so we feel like, based on understanding the geography, the politics of the individual state, where these facilities, the reach that they kind of span, that makes sense. You get into another state, so North Dakota, we're well established and stood up. It would make no sense if we only got 5 of 23 critical access hospitals to join a CIN. It doesn't have the same relevance to payers, and it doesn't spread the cost of infrastructure out in a way that is meaningful. So we look at scale for developing these individual networks state by state, and we really lean on the kind of core leaders, the CEOs that are pushing for this. And there's typically 4 or 5 that get them going in the state. They have to feel comfortable and feel like it's a good investment as well. Then on the national level, what has been a really cool byproduct of us building these networks state by state is the national payers now look at the Cibolo supported or managed CINs kind of as a single entity. So when you think about United Health Group and Humana and some of these national payers, and they have one point of contact for all of our networks, and we have one point of contact. So instead of having to go state by state, negotiation by negotiation, we can really pool that aggregate scale cross network to get much more. And to Zach's point, we started with administrative burden. That's where we began. Let's 2%. If we can get 2% less administrative burden for you, the payer, as well as for us, the provider, that's a win. And just been fostering and growing those relationships. So now we've got our point person at United. We've got our point person at Humana. They help us to build meaningful contracts that make sense in all of the states that we have a presence.
Yeah. So it takes time, right? And
Yes.
building that out for sure. We have a question. Sean has a question we received. Sean?
Yeah, so I think this is timely. And I think this is a little bit more for you, Brittany, which is, it goes to one of Zach's misconceptions around, boy, the clinicians are going to be overwhelmed by this. So let's talk a little bit about that. What's going to be the same for clinicians, and what's going to change?
So in our model, we have the board of directors that are appointed by the membership, and then there are 3 core delegated committees that advise the board. No contracts move forward to the board for signature. 100% of the clinical strategy is coming from these delegated committees. So every member is expected to have 1 provider and 1 non-provider clinician that sit on our CIC, which is our Clinical Integration Committee, and our CCC, our Care Coordination Committee. What happens within that group is really setting the strategic direction for how we integrate clinically. So out of that comes, you know, you got to get a provider committed to attending a meeting every single month, engaging, then bringing the information back to their peers, getting feedback. We also do annual in-person and education every single year. So once you get kind of your committed person, what ends up happening after a few months is our goal is care team support. So we don't bring any new work to the table that isn't offset by something we're taking away. So one of the things that we did this year is we did a huge RFP process, came up with an EMR technology agnostic AI and ambient listening option, and negotiated a really competitive price. We've got a great partner in doing that. So it makes this type of work, I mean, that's where everyone's going, and these large systems that have been participating in value-based care and have been largely successful, they have technology and infrastructure that helps them. So we're trying to do, to take away something or add value. And I bring the AI ambient listening example forward because in my 25-year healthcare career, I'm clinical by background, you know, there are very few things that physicians have said, this has made my life, this has changed my life for the better. Like that doesn't happen a lot. When I was rolling out EMRs, they didn't tell me that. So, you know, trying to come up with solutions that make the workload lighter. Centralized care coordination is another example. And then the other thing that I would say is, you know, we've of course had some naysayers that are like, I don't want to sit in a committee once a month and talk about this stuff. Then you get 6 months in and they're like, holy smokes, the quality measures that I said in the committee are the ones that are important to me. You actually delivered on it in contract negotiation. So now we're doing the 5 that we picked instead of 16, and 4 of them had relevance or whatever. So not to be you know, looking at the world through rose-colored glasses. There's always work that goes along with this kind of stuff, but we do work very hard to try and take stuff away that isn't meaningful and doesn't add value.
Well, I think that's really interesting. You think about it as a zero-sum game, right? If you're going to add something, you're taking something away, which I would think would resonate. And then the whole notion of finding a thought leader, somebody that's willing to be, you know, out front, and that's a good strategy, especially when you have that success 6 months down the road. So thank you for that.
Yeah. It's also very interesting. You talked about AI and ambient and what's coming, and as technology is certainly being changed dramatically every day. And that's a whole nother webinar on AI we could talk through, but it's true. And this, you know, by CINs and so forth, I'm sure are looking at that in multiple different ways. But so that's very interesting. And we can talk more about that maybe later. But we are rounding third on today's webinar, Headed Home. So real quick, we talked about what, why, how. What is from a CIN standpoint? We talked about joining versus forming, operating strategies, including the leaders, payers, team change management, you know, a little different tech stacks and so forth, AI that is coming that can make a difference. So I want to wrap up today with just talking about the first 90 days, readiness. And Zach, I'll start with you. If you kicked off, you know, just say next quarter, next year, 2026, what would your 90-day plan include?
It's nothing I haven't said before. And Brittany, I loved your previous answer. I'm learning from you, so that's really helpful. Thank you. I think my first 90 days really, as I alluded to earlier, has to be all about governance, transparency, and clarity for my members. If we don't nail that, this just simply isn't going to work. So really making sure that we finalize governance structure, voting structure, decision making, ensuring that the EPHC network has decision making power, equitably to Western Healthcare Alliance? Does that mean it's a joint venture? Does it, do we have other guardrails that we put in place? All of those things are really important for the independence we discussed, as well as creating comfortability for my members to say, yes, we understand what this is going to look like. We feel protected. We feel like they are good partners, and we know what we're getting into, right? We understand what this is going to look like, so that there aren't surprises, and that ideally we're removing some of that administrative burden from some of our providers straight out of the gate would be a great win. The early phases of driving data and care coordination, not just the infrastructure, but the adoption of it, creating the appropriate committees at the member hospital level, so that they're engaging with the hospitals or engaging with the data in their population proactively and doing their part on behalf of the entire clinically integrated network. And then, for me, like I said, we need to get hospitals to say yes and join. And I really am hopeful for 3 or 4 of our hospitals to jump in as early as Q1 or Q2 of next year. So that's what good would look like for me if we're talking a year from now.
Yeah. Well, good luck with that, as well as, what I heard you say, there's buy-in. You got to get buy-in. You got to show reasons. And Brittany, just to close us out today, from your implementations, what do you see that accelerates progress here? Something to avoid, maybe.
Yeah, I agree with Zach. It's a lot of what I've said. I think one thing we've learned time and time again is you can't assume that everyone's journey in value-based care is equitable. So these are still independent facilities with different experience and nuanced needs. So there will never be a day, and that's why a lot of our model is so flexible, is that the needs are really different. If I flip your question a little bit, Jared, and say what are our established networks going to be spending the next 90 days doing? I think that they're feeling really thankful that they saw the vision, a couple of years ago and got these networks up and going and have formal governance. As the OB3 dollars start to flow and know that CMS has very clear expectations about accountability and sustainability, they're really going, okay, this is an exciting opportunity for us to do a couple things: accelerate our strategies that we already had on the table through some additional resourcing. They feel very optimistic that they've got nonprofit formal governance structure in place. So they're kind of going at this together instead of trying as a single critical access or small hospital. How do we administer these funds in a way that's not going to get us in trouble or clawbacks? I think they're feeling really good about that. And I also think feeling like this is our opportunity to engage with payers really differently than we have historically. So these networks are saying, okay, this is our chance to come at the payers with some RHT dollars in play to really build value-based care arrangements that are meaningful, sustainable, relevant to rural facilities in a way that maybe we haven't had the same attention historically. So that's kind of our next 90 days is planning and strategizing. How do we position these networks, and how the networks position themselves to really make good on what the commitment of each state is for the use of these funds.
Right. Very good. Well, thank you for sharing that. And we have come to the close of today's webinar. Thank you, Brittany and Zach. Very thoughtful perspectives. Thank you, Sean, to the Azalea team that's in the room with me for putting this together. And, it's we live in a really amazing time for rural health. And, I think today the discussion made CIMs feel a lot more tangible. Zach, You and Brittany, you kind of brought out a lot of different things, and I'm certain you answered questions for the individuals that attended. I know you helped me understand it more. So thank you again. We appreciate your participation and your time. So before we go, a couple quick reminders. Today's session was recorded. We'll email you a link. Watch it again and again. And then when you exit, you're going to get a survey. And I've been asked to make sure that you give us good feedback. Please take a minute to fill it out. So speaking of next sessions, our next webinar will explore how practices can better navigate deductible reset season. Deductible reset season is upon us by reducing friction in patient billing and payments, covering why cash flow dips happen, small workflow changes make a big impact. The patient is a huge payer now. Make sure you're getting your dollars and you have a strategy in place to do that. So watch for the email invite. It's coming up, and I'm sure it will. It's going to be a really good hour on that as we look forward to the next one as well. Again, thanks everyone for attending. Have a great day, a great Turkey Day, and enjoy watching this again. That's a wrap. Thank you.
Thank you.
Thanks, everybody.
Thanks, Jared.
See you.